without further ado, let's proceed to your inflammatory bowel diseases. So when I'll be talking about inflammatory bowel diseases, there are two main inflammatory bowel diseases here. We have your ulcerative colitis and then your regional enteritis. We'll try to tackle them as a whole and then later on separate them and then later on review how are they alike and different from one another. When I talk about inflammatory bowel diseases, inflammatory meaning there is inflammation. Okay, the cause of this is idiopathic. Okay, it's unknown. There are a lot of risk factors, but it remains to be unknown when it comes to the direct cause. There is a strong familial predisposition when I talk about inflammatory bowel diseases. So, it is characterized by inflammatory processes and irritation, which leads to poor nutrient absorption, and that would depend on the site that is affected. Okay, may that be your small intestine, so you will have a big problem with malnutrition because area of absorption of nutrients is primarily on the small intestine. If large intestine, you will have a big problem with dehydration. And then the next problem is increased peristalsis. That's why your patient is having diarrhea. And then dehydration, fluid volume deficit, and then later on electrolyte imbalance. So this is the simple thing that happens in your inflammatory bowel disease. Simple as it may sound, there are a lot of things that we need to remember. When I talk about inflammatory bowel disease, again, there are two kinds, ulcerative colitis and regional enteritis. One thing that you need to know is that another name of regional enteritis is Crohn's disease. Let's start with the area being affected. Ulcerative colitis. When I say ulcerative colitis, okay, recall the word colitis. So the affected part is the colon. Okay, it affects the colon, probably the rectum, the sigmoid colon, descending colon, transverse colon, ascending colon. When I say regional enteritis, okay, recall the term enteritis. That would refer to your small intestines. So your regional enteritis affects your small intestines for that matter. Now, let's try to differentiate them. As I've mentioned, colitis. So it affects your large intestine, your rectum to cecum. Your regional enteritis or Crohn's disease affects your small intestines and then commonly the terminal ileum. If you can recall the three sections of your small intestine, that would be your duodenum, jejunum, and ileum. In this case, the ileum is affected primarily. Now, because of those areas affected, you don't need to memorize this. You need to familiarize the anatomical position of those areas. I mentioned large intestine, rectum, and cecum, and that can be found on the left lower quadrant. If I talk about terminal ileum, that can be found on the right lower quadrant. Okay, so you know where the pain is more likely to be located if we're talking about UC and CD. Then, let's have the degree of injury or degree of inflammation. In your ulcerative colitis, it tends to be continuous. Okay, maybe colitis continuous will help you remember. Regional enteritis, it tends to occur in patches. How will you recall that? Regional. Okay, it's not all throughout the small intestines where it occurs. It only occurs in specific regions, meaning patches. And the thing with your ulcerative colitis is that it does not extend to other layers. Okay? Its focus is on the mucosal and submucosal. That's a layer of your large intestine. Whereas your regional enteritis or Crohn's disease has a tendency to extend to other layers. Okay? Which means there will be at risk of fistula formation. The higher risk for fistula formation is in your regional enteritis because again, it penetrates other parts of the small intestine and then penetrates other organs. If you will be asked, who do you think will be at increased risk for peritonitis? Will it be a patient with ulcerative colitis or regional enteritis? Okay, so try to answer that question. Now, when I say ulcerative colitis, okay, we always go back to the first topics that we discussed. So colitis, I say colitis. So underline here, entire length of the colon. And then only the mucosal and submucosal layers are affected. Important keywords you need to memorize. Causes, as I mentioned, idiopathic. but it could be because of infectious agent, allergic reaction to milk protein, psychosomatic fury. When I say psychosomatic fury, there is an underlying psychological or mental health issue in your client, and then it manifests somatic. It manifests in the body signs and symptoms. So psycho, mental health, somatic refers to the body. So these are bodily expressions of the mental health problems of your patient. Then genetic predisposition, as we have mentioned. And then altered immunologic mechanisms. So your inflammatory bowel disease has an immune system component. Okay? For others, they say that this is an exaggerated immune response. That's why there are medications which are given to halt the immune response of your patient. So pathophysiology. As I've mentioned, mucosa first, then submucosa. They have the tendency to become engorged and very friable. Because of that, risk for bleeding. It usually starts distally. So it may start from the rectum, descending colon, going towards the transverse colon, going towards your ascending colon. So it's from distal to proximal. And then because of the multiple irregular superficial ulcerations and the development of your crypt abscesses, there is increased mucus secretions. And with this increase of mucus secretions, blood and mucus and pus are clearly visible in the stool of the patient. Later on, as the inflammation progresses, some area of the bowel slap off. Then some parts of this area are healed with normal mucosa, while others are being replaced by scar tissue. That's why in the long run, there will be scarring in the large intestine. And the scarred areas of your large intestine are at higher risk for development of carcinoma. Other than that, these areas may not be effective already to participate in the digestion process. So what are our assessment findings for a patient with ulcerative colitis? 1, there will be diarrhea. In the acute phase of this disease, the diarrhea may be even 10 to 20 liquid stools per day. Second, there will be left lower quadrant pain. You know the location of your colon already. Third, there will be intermittent tenesmus and rectal bleeding. So you know tenesmus. Tenesmus is occurring in your rectum. So you know that it's related to colitis already. Then anorexia, vomiting, weight loss, and dehydration are all because of the dehydration brought about by diarrhea. Then there will be presence of pus in the stool, fever, and anemia. Then, if you would look at this, these are the most common sites of ulcerative colitis. So you have your proctitis here, and then you also have your proctosigmoiditis. Then this is a comparison of a healthy colon and an ulcerative colon. So if you can see the picture surrounding this video of mine, so this is a healthy colon. But if you look at the colon, ulcerative colitis, you can see that the lining are very red, and as if there is swelling or inflammatory processes ongoing there. So that's how you would differentiate a healthy colon and an ulcerative colitis. So this image is obviously taken using your colonoscope. This also shows your ulcerative colitis, so with the bleeding parts there. This is an image of severe ulcerative colitis. As you can notice, there are mucous membranes here, or there are mucus, mixed with blood. And then there's severe swelling and ulceration on the surrounding tissues. So diagnostic tests, we would want to know if there is blood in the stool, so your fecal occult blood test. We would also want to check for the presence of your ova and parasite. We would like also to confirm if there is a hemoglobin and hematocrit decrease. Remember that your hemoglobin and hematocrit decrease is related to bleeding also. WBC is usually increased because this is an inflammatory process. It would also confirm if there is presence of infection. Your albumin has a possibility to be decreased because protein could not be absorbed well in the body. And then electrolyte imbalance is more likely to happen. For that reason, your patient may need to undergo sigmoidoscopy, colonoscopy, or barium. Barium enema for that matter. So because we want to make sure what the patient is feeling, or what's the underlying images when it comes to your colitis. Then complications. So you have the following complications that you need to search on. So try to identify the meaning of toxic megacolon, perforation, and bleeding. Also try to answer the question, how can ulcerative colitis lead to these complications? You may pause the discussion from here. Now, when I talk about toxic megacolon, this usually affects the transverse colon, characterized by the lack of peristalsis. So it is manifesting as fever, tachycardia, hypotension, and even dehydration. Then we also have perforation. Okay, for your perforation, it's rare because remember, the layers only involved in your ulcerative colitis are your mucosal and your submucosal layers. So in that case, perforation is rare. But then, there is a risk for peritonitis. And then bleeding. So the risk for bleeding will always be there because we're undergoing a major surgery. Now, so this is how a colonoscope would examine your large intestines. As you can see, the colonoscope could only reach up to your ascending colon for that matter. Then, this is how a barium enema would done, wherein a barium liquid is instilled into the large intestine through the anus. And then it aids on visualization of the large intestinal contents. Now, if my patient would have ulcerative colitis, these are the management for our patient. You should increase the calorie of the patient and protein intake of the patient. The purpose of your calorie and protein intake is that it's intended for the recovery of the patient, so as with the vitamins and minerals. Now, you need to decrease fats and fiber in the diet because remember, your patient is already having GI irritation. Giving fats and fiber could possibly irritate your patient's GI worst. Okay, so decrease that in the diet. We also give lactose-free formula for these patients. In the acute stage wherein the patient could not eat, TPN is recommended. So when I say TPN, TPN is total parenteral nutrition. And then cold food and smoking increases intestinal motility. Hence, it is not recommended for you to use cold drinks if ever you have stomach upset. Because if you have stomach upset, the tendency is that it will be worsened by your cold food and smoking. For the management of your ulcerative colitis, your sulfasalazine is actually an antibiotic, which is the drug of choice for your ulcerative colitis. Then we have your anti-diarrheal drugs, your corticosteroids, and then your immunosuppressive drugs. So your corticosteroids and immunosuppressive drugs are, as I have mentioned, there is an inflammatory component in your ulcerative colitis. So to halt the inflammatory processes, we are giving your immunosuppressants. Steroids are also immunosuppressants or anti-inflammatory drugs for that matter. Then we have your other kinds of antibiotics. Now for the surgical intervention, an ileostomy is recommended. Now, wonder, colitis, colon, why is it that are we recommending for ileostomy as a surgical intervention? Why? Now, other surgeries that could be done for the patient is total colectomy. So that is intended to treat the disease and to repair complications. So again, your complications would involve your toxic megacolon, your perforation, and then your hemorrhage. There are cases or patients who would opt for a prophylactic surgery before it progresses to cancer. But the question remains, why ileostomy if the problem is colon? Try to answer that question. In the succeeding slides, we will be discussing about Crohn's disease. So take note that another name of Crohn's disease is your regional enteritis. So when I talk about Crohn's disease or regional enteritis, take note that this is a chronic inflammatory ulcerating disease that affects any segment. If you can recall, I emphasize on the word regional because it can possibly affect any segment of your small intestines. In fact, it can actually also affect your large intestines. So it's regional, it's patches. Causes, idiopathic, there's familial, genetic hereditary factor, and then it is also considered to be autoimmune in nature, just like your ulcerative colitis. If you can notice, these are some of the patterns of your regional enteritis. If you can notice the first picture on the left, it is only the ileum which is affected. And the second pattern here on B, it is the ileocolic. And on the third pattern, it is the colon itself. However, it's not the entire colon affected, or it's not straight parts of this colon which are affected. Instead, it is some patches of this colon which is affected. Now, let's talk about the pathophysiology. So, it's just like your ulcerative colitis, there is inflammatory processes involved. Now, separated segments of the bowel are affected. That's why on imaging studies, it would appear as cobblestone appearance. Okay, it spreads progressively in the mucosa and then later on the intestinal walls. Because of that, there will be superficial ulcerations or aptoid lesions with granulomas and fissures. And because of the spread to the transmural layer, there is a tendency that there will be a fistula and abscess formation. So when I say fistula, there is an abnormal opening or abnormal access between two organs. Okay, it's just like, for example, your anorectal fistula. Okay, for example, your large intestine with a fistula going towards your small intestine. So meaning it's an abnormal passageway. Okay, and then there will be abscess formation. Abscess will be the deposits of your pus. Again, this is related to the effect to the several layers of your intestines. Unlike in your ulcerative colitis, wherein the effect is confined only to the mucosal and submucosal layer. For your regional enteritis, there is a possibility for transmural involvement. Now, by the way, the same thing that happens in your ulcerative colitis, when there is continuous inflammatory process, what happens is that there will be healing, and then later on some parts that healed will become scarred. Okay, assessment findings. The pain will be prominent on the right lower quadrant because remember, the main area affected here is your ileum. There will be diarrhea. However, the diarrhea seems to be soft, semi-liquid. Okay, there is blood in it. Why is it considered to be semi-liquid? Consider that the effect is on the small intestine. If the parts affected are on the small intestine, there is still an opportunity for the fluid to be absorbed in the large intestine. There is an abdominal tenderness and spasm. Fever is present. This is an inflammatory problem. Anemia is present because of bleeding inside. Nausea and vomiting. Then weight loss. Weight loss basically because there is a problem in absorption of nutrients, which supposedly normally occurs in the small intestine. Then you have malabsorption with steatorrhea. Okay, so malabsorption. Okay, malabsorption syndrome. Okay, your nutrients are not absorbed properly. It goes out of the GI system. Steatorrhea, presence of fats in the stool because your fats could not be metabolized properly in the small intestine, wherein supposedly it would mix with your bile and other acids, okay, for it to be metabolized. Now, chronic symptoms. You expect this one to be chronic, just like your UC. Okay, so diarrhea, abdominal pain, steatorrhea, anorexia, weight loss, and nutritional deficits. There are also manifestations outside of the gastrointestinal tract. Okay, because take note, there is an autoimmune factor. So some patients would complain of joint disorders, skin lesions, conjunctivitis, and even your oral ulcers. So this is an endoscopic image of Crohn's disease. So as you can see, there is an inflammatory process involved. And then there is aptoid ulcers there. Okay, the one which would appear yellowish on this image. Okay, so this is also your regional enteritis. Okay, this is a part, if I'm not mistaken, this is a part of your large intestine. So medical management. During the acute phase, you need bed rest. Why bed rest? You have malnutrition problem. Your patient does not have enough nutrients. Okay, so bed rest is recommended for recovery. Other than that, if your patient is moving a lot, the tendency is for the peristalsis to increase. And in this case, we have diarrhea. We don't want peristalsis to be increased. Replacement of fluids and electrolytes. Your potassium will be at high risk of being lost because remember, potassium is primarily stored in the GI tract. Medications. You give your anti-diarrheal drugs, loperamide for that case. Antispasmodic medications such as your propanthelin, glycopyrrolatin. Okay, so antispasms, they stop spasms. Antimicrobial agent, just the same with your ulcerative colitis, sulfasalazine is the drug of choice. And then your steroids and anti-inflammatory or immunosuppressant drugs. Because again, there is an exaggerated immune response here in your inflammatory bowel diseases. Then dietary management. Same, if the usual dietary regimen would not work, we need to have total parenteral nutrition, which is administered via a central line. Then you have elemental diets. So we decrease residue. Okay? We don't want fiber in the diet this time because our patient is having diarrhea. We decrease fat because fat will not be digested. Okay? The fat will not be digested properly. Food to avoid: cocoa, chocolates, citrus juices, cola, carbonated drinks, nuts, seeds, popcorn, and alcohol. All irritants to your intestines. Okay, so we need to avoid those. Then, surgical interventions. So your surgical interventions are only done to treat the complication of the disorder, such as your perforation and hemorrhage. Okay, so try to look into the image of iliotransverse colectomy, if what do we mean by that. And then try to ask yourself what will be the purpose of ileostomy this time in regional enteritis. Then partial colectomy. So when I say partial colectomy, a part of the colon is being cut. Okay, remember that the proximal end of your ascending colon may be affected because it continues to your ileum. Then you have anastomosis of the healthy bowel. So when I say anastomosis of the healthy bowel, you tend to combine those healthy parts. Okay, so what happened here is that they cut the parts which are not functional, and then they try to anastomose the parts that are still functional. So you refer to that one as anastomosis of the healthy bowel. Diagnostic test, imaging study. Okay, a proctosigmoidoscopy may be done if there is involvement of your procto and sigmoid. However, that will be minimal, okay, because this is we're referring to your regional enteritis. We also check stool for occult blood because after all there could be bleeding. Okay, barium enema is still one of the most conclusive, test because it would show you the cobblestone appearance. Then you have your string sign. Your string sign is a string-like appearance of a contrast-filled bowel loop. Okay, oftentimes we refer to this as string sign of Cantor. Cantor was the one who discovered this. So your string sign is a string-like appearance of a contrast-filled bowel loop. Okay, then you have your CBC. For your CBC, you will be looking at hemoglobin, hematocrit. You anticipate them to be decreased. Okay, and that decrease is not a good sign. It's a sign that there's bleeding. WBC is expected to be increased because there's inflammation, there's infection. ESR is erythrocyte sedimentation rate. And when I talk about inflammatory disorders, if you can recall in our discussion in immunology and inflammatory diseases, okay, erythrocyte sedimentation rate would be increased. Albumin and protein not absorbed properly in the GI tract, so they would decrease. And with the decrease of your albumin and protein, you will have the next effect. Okay, there will be shifting of the fluids because of the lack of osmotic pressure, which is supposedly maintained by the albumin and protein in our bloodstream. So you would expect that there will be edema for your patient, ascites later on if not resolved. Then complications. We'll have intestinal obstruction. We'll have stricture formation. We'll also have perianal diseases, fluid and electrolyte imbalances, particularly as I've mentioned, potassium. Then you'll have malnutrition and then fistula and abscess formation, by which this is more common in the regional enteritis. Okay, so try to rationalize why is there intestinal obstruction? How come there will be stricture formation? Between the two, intestinal obstruction and stricture formation, what would correlate to the string sign that we have mentioned earlier? What do we mean by perianal disease? And how come the patient would have fistula and abscess formation? Okay, your readings on this topic would possibly help answer those questions. The nursing interventions, okay? Maintain normal elimination pattern. There will be diarrhea, so administer anti-diarrheal drugs. A stool count sheet at bedside. We want to check how many fecal outputs that our patient have. We want to replace those outputs. Okay, if our patient is not drinking fluids, we might need to replace the output with isotonic solution. And then again, encourage bed rest. It decreases peristalsis. It also conserves your energy. Energy needed for recovery. Then, relieve pain. Okay, by pain here, it's not just about analgesics alone. You give your anticholinergics. Because take note, if I talk about cholinergic, it's equal to parasympathetic, it's equal to excited GI tract. This time we administer anticholinergics. The purpose of administration of your anticholinergics is to decrease intestinal motility. Okay, we don't want the intestines to be too fast. Okay? Risk for dehydration. Risk for malnutrition. Then administer analgesics for pain. Then sometimes we tell our patient to change position, okay, so that we prevent pain, possibly bed sore related pain. And then we also advise them to have the position they're comfortable of. Okay, you might notice that there are patients with abdominal pain who would love to assume fetal position. Okay, because the fetal position would possibly relax the abdominal muscles, decreasing the pain and the tension that they have. Then encourage diversional activities. By diversional activities, we educate our patient that they can focus their attention on other substantial matters that they need to work into, and not only on the pain experience. That way, it can possibly reduce the pain of our patient. Then, maintain fluid intake. As mentioned, low residue, low fiber. That's what we meant by low residue. Low fat. Promote rest, reduce anxiety, and then prevent skin breakdown. So turn to sides every 2 hours for that matter. Now, we are done with our discussion on ulcerative colitis and Crohn's disease. Let us recap, okay, or let us have additional input on what we have learned on their difference. Okay, so an additional input, ulcerative colitis would usually affect the extreme of ages, 15 to 35 and 50 to 70. These are the usual age of onset. For your CD, Crohn's disease or regional enteritis, the age of onset is playing at 10 to 30. The disease UC is usually chronic and intermittent. Okay, meaning it stops, then goes back. Then progressive, your CD has a tendency to become progressive and then it relapses. And then the depth of involvement, as I have mentioned, the risk for fistula formation is higher in regional enteritis because of the transmural involvement. Portion affected, ulcerative colitis, talks about colon. So that's your rectum, sigmoid, and then your ascending, descending, transverse colon. Crohn's disease, regional enteritis. Enteritis is your small intestine. Then you have your distribution. For ulcerative colitis, your ulcerative colitis has a tendency to be continuous, whereas your Crohn's disease has a tendency to be patchy and skip lesions. Hence, the cobblestone appearance. Then, as mentioned, cobblestone appearance for your CD. On the other hand, for your UC, it has a tendency to be granular, friable, and hyperemic. Higher risk for bleeding. Abdominal pain here is addressed by the location of the common site. So ulcerative colitis would usually affect your rectum sigmoid, and then your descending colon, hence left lower quadrant pain. Crohn's disease usually affects your right lower quadrant because that's where your ileum is. Okay, so cramping pain, steady pain, and sometimes radiates to the periumbilical area. Diarrhea in UC is severe. Okay, why? Colon is affected. Colon is supposed to absorb water, but this time colon is inflamed. Colon could not absorb water. So hence, severe diarrhea in UC. In CD, although we could not ignore diarrhea, but it's less severe compared to that of your UC. Okay, why is less severe? Because colon is probably functional. Colon could still absorb water. Okay, and then there will only be a semi-soft to liquid stools that would appear. I hope that this table would reiterate the difference between the two diseases. Their management, their medical management, and their nursing management are almost the same. Okay, but you need to differentiate between the two for you to care properly for your patient. Level 3, once again, I would like to thank you for your kind attention.